right-sided tumors, not at all, but I would use it in later lines because I do believe there's still some patients who respond because we just don't understand things well enough. I want to skip over this here, but I want to kind of go back to the idea that right and left-sided tumors are different. Now, I mentioned something very early on the microbiome. And I do believe we're just scratching the surface of what the microbiome really does to our biology of total cancers and the interaction with treatment effect. And I want to show you some interesting new data. So first of all, the hallmarks of cancer, this Johns Hopkins-based analogy here, which looks at the tumor host interaction and the biology and whatever we can target, has one missing part, meaning the interaction with the outside world. This is tumor host interaction, immune system, microenvironment, etc. But the outside world, another organism living inside of our body, the microbiome is not accounted for. And I give you some interesting data. And I learned today something that babies born by cesarean section compared to vaginal delivery have differences in the microbiome. They have less bacteria in their gut. And how important is the composition of microbiome? So this is melanoma patients. Melanoma patient with metastatic disease. It has nothing to do with colon cancer. Melanoma patient, metastatic disease on immunotherapy. And the interesting thing is the likelihood whether they respond or not respond systemically, liver, lung metastasis to immunotherapy, melanoma, depends on what microbiome they have, what bacteria they have. And you can plot different survival curves based on bacteria colonization. That is Science 2018. That is brand new. Just, scratching the surface. In colorectal cancer, end of last year, against a Science publication here based on, very prominent players, Josep Tabanero and Charlie Fuchs, from Dana-Farber, they looked at bacterial colonization of colorectal cancer and their metastases. And they found, first of all, this Fusobacterium nucleatum is commonly found as an infection in colorectal cancer tissue. When tumors metastasize, they take the bacterium with them. You can find the same bacterium in 80% of the metastases. You can actually put a little schema here, primary tumor metastasis, etc. Now, also when you transplant these tumors into xenografts, the bacterium carries with itself. So even in xenografts, you have bacterial colonization. And when you treat these tumors now in xenografts with metronidazole, you actually see an impact on growth. That shows very clearly that the microbiome interferes or interacts with the biology of cancers. And I can tell you in 5 to 10 years, we'll probably do an analysis not just of tumor molecular factors, but also which microbiome you have. We might actually not only treat the cancer, but also the bacterial colonization we have. That's the next step in the management of our patients. We talk about probiotics. I've laughed off probiotics for most of my life. Now I'm taking them. In addition to aspirin, which everyone should take. So those are things which, is really interesting. And again, we're just scratching the surface like we did with immunotherapy for a long time. My PhD thesis was immunotherapy of kidney cancer, 1988, and I slammed it. I never thought immunotherapy for cancer would work. Now I need to reconsider 30 years later. Anyway, sidestepping. Now let's talk about conferences. Let's talk about news from conferences. I think the most important data set we had from ASCO is actually on HIPEC. So HIPEC is something kind of controversial. If you have a HIPEC surgeon in your group, you think, HIPEC is the best thing in the world. If you don't have a HIPEC surgeon, you say, no, we don't need it, So what do we really need? The need was randomized trials, randomized data, because, until recently, until this study, we really didn't have good modern treatment approach randomized data. So this changed with the French study PRODIGE 7 or Accord 15, and they randomized patients actually during surgery to treat them with HIPEC or not. So background is, of course, and this is analysis actually from the Mayo Clinic database, from the Mayo Clinic base database. We know that patients with peritoneal disease, peritoneal only, for instance here, do very poorly. There's overlap with BRAF mutations, of course, so these tumors are more aggressive, but median survival in this pooled analysis of almost 10,000 patients in the database showed that this analysis 16.3 months median survival. And peritoneal disease, again, whether it's in context of liver metastasis or alone, is a very poor prognostic indicator. Now, what the trial did here, they had 265 patients, and they had, the peritoneal involvement index, they had, potentially resectable disease. And during surgery, where they actually removed tumor tissue to less or equal to 1 millimeter maximum depth of the cancer, so radical side reductive surgery, CRS, they randomized patients in the OR to use HIPEC in form of IP oxaliplatin for 30 minutes and IV 5-fluorouracil or no HIPEC. And they received chemotherapy afterwards, etc., so received standard of care. Now, there's no difference. There's no difference in outcome and overall survival. But the interesting thing is overall survival was extremely long in both groups. Like I showed you earlier, peritoneal disease by itself, of course that's a big bucket because peritoneal disease can be very extensive or less extensive, 16.3 months median survival. Here with side reductive surgery, with or without HIPEC, over 41 months. And no difference between HIPEC or no HIPEC. Now, there was actually a discussion at ASCO about, it was a HIPEC surgeon who actually did the discussion after this presentation, and they had a lot of explanations around why this wouldn't work. I mean, if this is your toy, your tool, this is what your life is dependent on, your professional life, of course you defend it. And they said, chemotherapy duration was too low, too short, 30 minutes, we normally 60 or 90 minutes, and there's a certain subgroup of patients with peritoneal involvement that might still benefit in this forest plot. But overall, the data, these are the most reliable data we have right now. My enthusiasm for HIPEC has completely, not disappeared, but it's a lot less. If at all, I could consider HIPEC, and this is probably more radical, if you have a T4 patient stage 3, T4A, T4B, and these patients do poorly, what about adjuvant HIPEC? There are actually studies ongoing right now in Europe that look at this, and we have never been able to pull this off in the United States. So, great outcome, but likely due to the fact that side reductive surgery, debulking surgery, works. And when you look at what we're doing with chemotherapy, we do chemical debulking. We're reducing tumor volume and reset the clock and help patients live longer. Okay, relapse-free survival here, again, not statistically significant. The other thing that I want to talk about, ASCO update, FOLFOX plus panitumumab followed by maintenance therapy with 5-fluorouracil plus panitumumab. Why is that important? It's something that closes a loop for me, a missing link. We've never shown that there is any benefit of adding a fluoropyrimidine to an EGFR antibody. There are actually data from various studies that there might be some, actually non-synergism or even a detrimental effect depending on the fluoropyrimidine. So this Valentino study, nice name for a study, looked at FOLFOX plus panitumumab, and then maintenance therapy, either panitumumab alone or 5-fluorouracil panitumumab. And again, this closes a missing link for me because outcomes were better for the panitumumab 5-fluorouracil combination compared to panitumumab alone. We know panitumumab in RAS, RAF, left-sided to wild-type left-sided tumors is active, but it shows clearly there is a benefit for adding chemotherapy with a non-cumulative toxicity effect, not like oxaliplatin, to panitumumab. And it's actually designed as a non-inferiority study, which I'm always a little bit wary about, having presented non-inferiority data, in the adjuvant study, the idea analysis. They used a very high upper boundary of one-sided confidence interval. Bottom line is, there is data now, 5-fluorouracil plus panitumumab is better than panitumumab alone. The problem that I have with the study overall is, panitumumab is not the best maintenance therapy. Because when you keep patients long-term on the EGFR antibody, you run into the issues of skin rash with or without 5-fluorouracil. This is not something, it's not as benign, let's say, as for instance the fluoropyrimidine plus bevacizumab, where patients are not stigmatized. They can actually keep on these, let's say, capecitabine, bevacizumab for a long time without having any major side effects. Next study is it's probably more self-serving because it's one of our CRUISE studies from the Mayo Clinic with Tony Saab as the PI. is talk about how do we optimize regorafenib dosing. And you know, regorafenib is one of those not loved agents which provide some benefit, and we now realize it's probably more active than we thought. It's not loved because as an oral multi-kinase inhibitor, it has side effects which occur early. And this slide here shows you the first occurrence, this is days, so within 2 weeks, and worse, grade occurrence. And the time when patients come to their first occurrence, for instance, of hand-foot syndrome or rash, it is the worst grade they'll ever experience. So within the first 2 weeks, the patients will experience their worst toxicity ever on the course of the treatment. And that is, of course, concerning because patients get burned, physicians get burned, in particular when you use the starting dose of 160 milligrams. Patients after 2 or 3 days might call in and say, I will never take this drug again. So what we try to do is to optimize the dosing strategy, and the normal dosing strategy starts with 160 milligrams. We said per day, which is 4 pills. We said, why don't we start with 80 milligrams, half the dose for the first week, then escalate to three pills, 120 milligrams for week 2, then 160 milligrams for week 3, and then patients have a week break anyway, and the second cycle can then be used, the dose in the second cycle is being used according to what happened in cycle number 1. And the primary endpoint of the study was how many patients make it to cycle 3. Because, you know, you need to make sure that patients are not undertreated. So when you go to cycle number 3, it means you've had a first scan after 2 cycles, meaning after 8 weeks. The scan showed at least stable disease, so you wanted to continue. And you could continue because patients